Welcome to Healthcare Rounds. I'm your host, John Marchica, CEO of Darwin Research Group. Today, I'm pleased to announce we've got John Driscoll, and this guy has so many titles, so many different things that he's doing that I couldn't even put it into a single descriptor. So I'm going to let him start off and talk about his storied background in healthcare. But I'm really excited about today, and welcome, John. Thanks for taking the time to talk.
I'm delighted to be here, and yeah, no, I'm currently wearing a few hats. I have a background in social service and Medicare and Medicaid managed care, pharma services, healthcare technology. I'm now uh, chairing the Yukon Health Board. We've got a dental school, medical school, and a hospital system. I'm chairing a company called Waystar, which is a publicly traded revenue cycle software business, a healthcare technology business. And I'm the chairman of Magnet, which has got a lot of healthcare staffing. So I've got a finger in a lot of pots, but hopefully all moving in the direction of trying to solve what we're all trying to solve: improving outcomes and lowering costs.
Is it tough to juggle so many things at the same time? I feel like trying to do a podcast and run one small business is enough for me.
Well, I think, John, I'm really lucky to have great teams at
Mhm.
Waystar, at Yukon Health, and Magnet, and that makes it a lot easier. And it's as the chairman, you get to play, you get to help set the agenda, solve problems, and then let the hard work go to folks like you. So it's actually pretty much fun. And what it allows me to do then is to play a little bit around in AI and support some small companies and work with some entrepreneurs I know and like. And so it's the portfolio fits me right now, at least.
It sounds good. Well, maybe one day I'll have more of a portfolio approach to what I'm doing. For now, it's Darwin Research Group, but that actually, given your breadth of experience, John, it leads to a good start off big picture question, and I'll set it up this way. We've all watched Apple, Amazon, a number of new players in the market, Google. I can go on and on. Certainly, at one point you were with Walgreens. They've done a number of different initiatives in that area. Um, and from my lens, it's about sort of the future of primary care and how we're going to tackle delivering healthcare to the masses. But it's also in my business really kind of specifically into pharmacy. And and there's been a number of new companies that have come out. Mark Cuban's Cost Plus Drug Company. I'm hoping to have him on soon. And other similar kinds of new pharmacy benefit management models that all talk about transparency. So there's all of these little pieces around primary care and then specifically around pharmacy. And I just wanted to give you sort of a platform to start off and talk about where you see the future of pharmacy, where you see the future of pharmacy, of primary care, excuse me, given all of these new players that everybody's trying to figure out how they all fit into the pie.
Well, maybe I'd start, John, by just talking about pharmacy and PBMs, and then maybe hit primary care, because I do see them as two very different. They're very different problems, and they're in very different places. Everybody knows what local pharmacy used to be. There are thousands of pharmacies that people go to. They rely on them. They're a local source of healthcare advice. In some cases, the pharmacy is the only healthcare institution left standing. But that model of the local pharmacy, at the corner or around the corner, that's changing. And I think you're seeing, particularly post COVID, all of the models, Walgreens, CVS, everyone adapting to a mix of online, leveraging the internet, leveraging e-commerce, more personalized contact with your consumer, and logically a much smaller format, because what you used to have to actually leverage physical formats, you can now do through mail order distribution,
Sure.
direct distribution. And I think the cost of that infrastructure has risen appreciably over time, while at the same time the reimbursement has gone down. It's really hard to be a pharmacist in America right now. It's an essential service. One of the reasons why Medicare doesn't doesn't actually, there's no Medicare fee schedule. There's no fee schedule, healthcare fee schedule for pharmacies, because it used to be that the pharmacies made enough margin on the prescriptions that they didn't need any other sources of income. But that's really changed with the mix of drugs that now go through local pharmacies. The actual cost of most standard chemical compounds like rovastatin has gone down to pennies on the dollar. And a lot of the expensive drugs, branded drugs, and the specialty, the infusibles, have gone through the roof. At the same time, the PBMs have emerged. But I think that we're at a tipping point for local pharmacy where I think the CVS, the Walgreens, the Walmarts of the world are really rethinking the mix of physical versus centralized in their model. I think there's going to be a cost plus model that will emerge pretty darn quickly, because we have to find a way to finance and support the pharmacy infrastructure we need. And I think the PBMs, which have, I think, served a really good purpose of trying to tamp down trend and negotiate with big pharma, got too big and too powerful. And frankly, the lack of transparency allowed them in many ways, for many people, really believe that they kind of cheated their fiduciary duty of really doing the best job to manage pharmacy cost trend. And I think you're going to see new economic models on the pharmacy side, even though there'll be a smaller number of stores. You're still going to see pharmacy, because I think local pharmacies, pharmacists, I think, are an essential part of the community, and political leaders and community leaders understand that. And I think that, big PBMs making $7 to $8 billion a year, when they can't justify some of the cross subsidization they do that basically lines their pockets and doesn't deliver a lower cost. That is one of the few things that, the PBMs have, like the government of China, have succeeded in uniting Democrats and Republicans to agree on one big thing, which is the PBMs need to be reformed. And what that's going to mean is, I believe those profit pools are going to go away. I think that'll bring down drug costs to some degree in trend, and you're going to see very different models. But I think we're at an interesting tipping point in pharmacy where I think the models for both local pharmacy, how they're reimbursed and how many there are, PBMs, those big central powers that have been controlling a lot of the management of that part of the benefit. I think you're going to see a big regulatory crackdown there. And I think it's high time. You just have to look at the FTC reports most recently, and there are prices that they're charging that are inconceivable with the mandate of lowering costs. And that's also going to create new entrants like Mark Cuban's cost plus drug, which I think is a really exciting alternative to a lot of buyers. Now, let me pause there and see if you've got any questions on that, and then we can get into primary care, which is another one of my favorite topics.
Yeah. My follow-up question is, I don't see a lot in pharmacy of sort of this consumer thrust. We saw this starting probably 20, 30 years ago on the hospital side and the provider side of patient satisfaction, this kind of thing, right? And improving patient satisfaction. And it was everything from, I remember very early in my career working on some sort of northwest suburban hospitals in Chicago, and like who has the best food, and like those were drivers, right, of success, of satisfaction, of happiness. But a lot of the conversations we're having today seem to be around the pricing models, the cost plus drug, the PBMs, and things like that. And I can tell you, as a consumer, I'm not telling you anything you don't already know. My experience with a handful of local pharmacists over the years and independent pharmacies are far, far better than all of the big stores. We can name them, but you've named some of them, on an ongoing basis. And then there's some confusion, I think, as to, well, when is this a 90-day supply, and when does it become mail order? So that really customer focus on the experience of pharmacy, in the same way that you experience going to the doctor's office, and really trying to make that. I feel like this is a long question, but I feel as if that on the provider side, they've made bigger strides than as a consumer on the pharmacy side. So how do
But
you put the
I,
patient
I
first?
I think that's right, John, but I think part of that is their economic model has really collapsed. I think 60-80% of the available margin that they used to be able to make has gone away, and so they've had pharmacists and independent pharmacists have often found multiple ways to make money that basically subsidize the pharmacy, as have some of the supermarket chains. That what you're saying doesn't surprise me, but you've got to understand it's in the context of the collapse of the economic model that would have funded that personalization and focus on service. But I think that we're going to, because things are changing, because they are right sizing physically, CVS and Walgreens have acknowledged that they're going to have a smaller footprint. And the
Hmm.
emergence of a cost plus model where you can predict how much money you're going to make, you're going to, I think, see more of that personalization. And they're going to, and I think they're also focusing, all of the large chains are focusing on more centralized distribution and e-commerce, which also allows you to personalize it. So I agree with you with the recent past, but I'm really hoping that with a little bit more transparency with a model where they can make some money, I'm pretty confident they're going to put that money towards personalizing the service to consumer. Because you're right, in many cases it's a lousy consumer. It's a consumer experience that could be substantially improved, and it's critical. Drugs are more and more a higher percentage of total healthcare costs. When I came in, they were like 3 to 5% of healthcare costs. Now they're like 20% and rising of the average employer's healthcare costs. We're getting to drugs that are far more powerful, and mixes of drugs that are both more dangerous because we need to make sure they're right, and more powerful because people are living longer and needing more of them. So it's a critical part of the healthcare value chain and the service value chain, and we have to get it right.
Yeah. Yeah. Well, I've got a few more on pharmacy. We can come back to it, but let's talk primary care, because there is that, kind of same thing with the Amazons and other non-traditional players, and even some traditional getting involved in wanting to extract a piece of that pie. I mean, even in the health system world, the big IDNs, right? They want to own some of that primary care, if it's an academic medical center, part of it, so that they can drive patients into their studies and the sicker patients into the academic medical center. So what are some of the key trends or some of the things that we should be looking for in primary care?
Well, I think the key in primary care on its own doesn't make any money for a hospital chain. It's got to be part of that referral stream, as you explained. But it's pretty hard to make much money as a primary care provider, particularly if you're taking all payers, commercial, Medicare, for the elderly, and Medicaid for the poor. What I think you saw over the last 5 years is an explosion of new models that was sort of subsidized by the Medicare risk product, where Medicare managed care plans would allow health providers to basically take care of people on a budget as opposed to fee for service. And so you'd be paid almost like a subscription service to take care of my 90-year-old mother. You'd be paid a fixed amount per member per month that would allow you to, it would be adjusted based on acuity and illness. That created a lot of really interesting managed models, some of which were very successful at both managing the care and making money. When Medicare came in and changed the reimbursement because they were frankly overpaying a lot of those providers, I think that shook up the system. But I think what you're going to see, what I predict you're going to see with the Trump administration, is as those regulatory changes have stabilized, honestly, taking care of people on a budget, really having a budget for chronic care where you're not charging for every pill and every procedure, but really managing that as part of an insured product. I think you're going to see more of that. But I'd be skeptical of people just getting into the primary care business, hoping that the referrals will bail them out, because that's one of the things that managed care is very focused on, is reducing unnecessary referrals. But if you get into the business of actually managing risk and managing populations and thinking about managing people's health, and these risk models come back, I think that could make primary care very attractive as a place to invest, and frankly, a place to be a caregiver.
Well, I remember seeing, and I'm sure I've mentioned this on the podcast before. I remember seeing Mark McClellan at least 10 years ago at an ACO conference showing this slide that I've borrowed for other presentations, but basically saying everybody in Medicare is going to be capitated, period. Whether it's in some sort of ACO model, which is still fee for service, but or as you were talking, Medicare Advantage, we want everybody in this to have that predictability, right? Because you want that, and as costs are going up and up and up, you're going to want to have that predictability. So I know it's been on the radar for a while, but I think the difference for me back compared to when I got started in healthcare back at Abbott years and years ago is you know how to keep costs under control. It goes back to the triple aim: how to keep costs under control while not just sort of deny coverage, which is the old school way of how you're going to make money. How do we improve healthcare for the patient at the same time? How do we improve the experience? How do we improve for populations? And so that's, to me, that's a key difference as they're moving in this direction. How do you continue to improve the quality, right, that you're getting in healthcare?
Well, I mean, one of the things that Medicare has done a pretty good job at is to lay out, from whether it's the HCAP scores where you're actually measuring the consumer experience of the Medicare managed care consumer, or some of the HEDIS and Leapfrog and other measures around quality. So it's not that hard to lay that out. What's hard to really lock on is what's the right budget. I mean, when Mark McClellan, the former head of CMS, put those predictions out, the assumption was that everybody in Medicare would be in Medicare managed care, but the uncertainty of reimbursement has led some companies to make a ton of money very quickly, not necessarily to get that piece right, and others to be kind of shaken up when the model changed. But that whole notion, capitation is just managing managing a population on a budget. And I do think that's the right model. The key is to mix in those consumer measures, as I think Medicare's done a really nice job at. I mean, today, your reimbursement is dependent on how good your consumer feedback scores are. And the health plans, I can tell you, are very focused on
Mm-hmm.
whether they or their delegated providers of any service are helping or hurting that. Secondly, they're very focused on the quality measures, or really less the quality than the measured by outcomes. How are you doing, not just against vaccinations, but in hospitalizations? So I think the measures exist. The hard part right now is at a time when there's something called version 28, which is the reimbursement schedule for Medicare providers that came out last year, that dramatically cut over the period of a couple of years how much Medicare managed care providers would be paid for these populations. That created a lot of regulatory uncertainty around future reimbursement that I think has shaken up the system. But once that stabilizes, which I think it will in the Trump administration because they're so pro-private sector, I think you're going to see those models continue to grow and refine. I mean, remember, we're kind of turning Medicare fee-for-service on its head. And while it's expensive, it's a pretty popular program and has been around for a while, since the mid '60s. We're only probably 5 or 10 years into true capitation in Medicare and Medicaid at scale. So I think the model's still being tuned.
Mm. Well, you mentioned the Trump administration. I think, what was it, yesterday? Was handing over the keys. Um, from your viewpoint, and let me, before you answer this, I'm just going to just say where I'm coming from it and what I saw. The first Trump administration, with respect to healthcare, I wrote a lot about it, and I felt like I was writing about sort of policy implications, and like everything else, it seems that politics gets into it, and then I'd get these emails saying, "What are you just bashing Trump?" I'm not bashing anybody. I'm evaluating the policies. I'm evaluating the notion of you know, not advertising, for example, or cutting out all the advertising for enrollment for the ACA, or some of the other things, shenanigans, frankly, that were going on in early going. But I don't think that on balance over the course of those 4 years that there was a destruction of, wholesale destruction of what was trying to be accomplished. It was more on the margins. Now I don't have a window into, other than maybe some potential appointments, but I don't have a window into knowing what their objectives are, what their goals are, what kind of what the implications for us as consumers, as Americans, of consumers of healthcare, what's coming down the pike. So, from your perspective, John, what's your early read on maybe some of the signals, and even if there haven't been signals, what are your expectations in the first couple of years of the new administration?
Well, I think I'm on record on a bunch of other podcasts as not being a huge fan of the incoming administration, largely starting at the top. But let's pause that for a moment. And with that, I think they're saying a lot of really interesting things around food as medicine, nutrition, and the mismatch of incentives that we have in agriculture and the food system that probably are making us ill, with all of the subsidies around corn and sugar, and the way we have chosen not to regulate big food and instead have had to pay big pharma to fix a lot of the problems that big food really is the source code around. I mean, we have an explosion in diabetes, and we've got massive sugar subsidies as a country. So I actually think let's talk the positives. I think that making America healthy again, starting with nutrition, is a pretty darn good idea. And I think that what's
Mm-hmm.
interesting is that all of the appointees that the president now inaugurated, Trump, has suggested are aligned around that, and that's going to be novel and hard because big food, big sugar, they spend a lot of money lining the pockets of legislators of both sides to lock in subsidies that frankly are making us sick. And I think that the more they can support innovative companies that are working in the food as medicine space, my wife happens to have a company called NourishedRx that's doing some amazing work. They've worked with, I think, 14 health plans and have never failed at changing the arc of healthcare costs with nutrition. But there are a number of great companies out there that are helping really reverse diabetes, reverse heart disease, lower the number of low birth weight babies by starting of integrating nutrition, behavioral science, and healthcare providers and insurers together as a team. That's going upstream to the problem. I think that's quite attractive. I think you're going to see just the nature ideologically of an administration that is more oriented towards private sector solutions. And I think they're going to, I don't quite know how they're going to interpret their general philosophical mandate to lower the regulatory burden on companies in general. I think that'll flow through to healthcare. I believe Mehmet Oz who's likely to be the running Medicare and Medicaid, the head of CMS. He's the nominee currently. He hasn't been through confirmation, but you look at he and some of the other talents that they put forward, don't underestimate them. They're all very focused on innovation and leveraging the private sector. But I think what's interesting, John, is once you get below the almost tribal fear of the ACA, the Affordable Care Act that many Republicans have, the policy wonks on the left and the right that are truly interested in solving problems in the private and public sector are pretty close. It's just a question of how much private and how much public, how much you regulate and how much you allow competition. But they're all interested in managing healthcare in a budget. They're all interested in changing the arc of the incredible increase in chronic disease. And they're also invested in really making Americans healthier. And it's going to be really interesting to see how that plays out. I think Dr. Marty Makary, who's the nominee for the FDA, is a scientist, a clinician. He's a skeptic about a lot of things that are not necessarily well researched. But I think he's, again, going to be if you look at the through line for the appointees in healthcare, they all have some deep experience in healthcare. That's not true of some of the appointees in some of the other areas. They are in general interested in this Make America Healthy Again agenda. And it's going to be interesting And they're all interested in increasing the role of the private sector. It's going to be interesting to see how that plays out. But I think it's a little bit premature to predict, other than nutrition being a novel and I think a pretty important and interesting thing that, again, Democrats and Republicans can agree on. It was interesting to see that Bernie Sanders came out and said he completely agreed with President Trump on that. So I think I'd look at where you're going to see novel places where there's bipartisan support, because in general, we rely on Washington to do nothing, do little, and talk a lot. This is one area where when two sides get together, things could change.
Well, that's a very positive spin on things. And I agree. If we can get focused, look, and I've talked about this before, I'm no miracle, but I don't take blood pressure medication anymore. And I did for a lot of years. I'm 25 pounds lighter than I was 2 years ago. And I can go on, but a lot of it has to do with nutrition. Things I don't put in my body, as well as the things that I prioritize that I do. And then again, it comes down to the accountability level at the individual, having people educated as to what to do. But I agree with you. It's crazy to say, well, we shouldn't have so much sugar in our diets, but then subsidizing the sugar industry. It's like, you can't say one thing and then on one side of your mouth and then on the other. The thing that concerns me, and I'm hoping that this isn't the case, was at least it was my sense back in 2016, 2017, into 2018, was that there wasn't a lot of thought about, let's say, do we keep the ACA or do we not keep the ACA? There wasn't a lot of thought other than let's eliminate what was done before. Almost like
tribal.
out of
It was just like
very tribal.
We'll just burn the village down and see what happens.
And that didn't make any sense to me at the time. I don't think it made sense to a lot of people. And so I would hope that that isn't the case. And I look at Robert Kennedy, for example, and I'm a huge believer in science, obviously. And I don't see a lot of evidence for some of the things that I hear come out of his mouth. And so I worry about...
He's a peculiar nominee, but I think you don't underestimate how important his votes at the margin were for President Trump. And I think he cut a deal, and we're, at least for the moment, it looks like we're going to be stuck with him. So I'm encouraged slightly by the fact that he's gone from his position that there is no safe vaccine to he thinks vaccines are at least should be available to people. He's a peculiar choice with no healthcare background to speak of. He just disagrees with things in the healthcare world, as many lawyers do. But I'm going to, I think for the moment, at least this week, John, let's be positive about the things that we agree with. And let's see what he says and does on vaccines. I think you'll see that Dr. Marty Makary, Dr. Mehmet Oz, the people who are beneath them, they're all strong believers. We have effectively increased lifespan in the 20th century by 50%. People are living that much longer because of clean water, decent waste disposal, a safe food supply, and vaccines, and antibiotics. I guess I throw in there penicillin and antibiotics as well, but they are absolutely essential to people living healthy and living longer. So with the view of make America healthy, let's keep America healthy, right? I mean, that's right. Maybe that should be the CAHA should be the alternative to MAHA. So you make America healthy, but let's start by keeping America healthy, and hopefully we can all agree on that.
Yeah, well, I think so. And that get back to RFK Jr. There are elements of the things that he talks about that make a lot of sense, and that's starting with nutrition. That's one of them. So, well, we'll have to see what happens. I know that we're limited in our time here, and I want to get to a couple more topics before we wrap it up. And one of them, I've got it, especially with your position with Waystar, I've got to get your take on AI. And it's such a huge topic that I know we could spend another hour talking about that, but really want you to think about, with everything that has been written, all the partnerships that are going on in AI, um, everywhere I turn. I mean, I feel like with our weekly piece that we write, I could write on AI every week. It's just so much going on. But where do you think, where's that key quick win? Where can AI, in your view, have the biggest impact? Let's say with the least disruption of all the different areas, clinical, financial, all these different areas we're talking about in healthcare. Where are you most optimistic?
So I think let's start with the notion that AI is really, once you take take the wrapping of the word artificial around it, it's basically big compute, better data delivered to you to answer harder questions in a more real-time fashion. What that should translate into for healthcare is to extend and improve the clinical and non-clinical care that patients are receiving. And so my hope, and I'm working with a couple of companies on this, is that we can solve what's a significant labor crisis over the next 10 years. We're going to have 1 million fewer clinicians, nurses and doctors and PAs and techs than we need. We're not educating enough of them. We aren't letting enough of them immigrate into the United States, and our country is getting older. Artificial intelligence, big compute, leveraging computational power at the edge of healthcare could be incredibly powerful at allowing a doctor to handle more patients and really focus on the patients and not on administrative stuff. Like one of the things we're working on in Waystar is how do we make the doctors' jobs easier by improving revenue cycle and using big compute and better data. But I think you're going to see, I would guess that the average physician spends 40 to 50% of their time on administrative tasks. If we can get rid of those tasks by bringing compute to them in a way that is seamless, relevant, and is integrated into their workflow, it's going to be a game changer. And I think it's going to be genuinely positive. And it's really focusing on extending, simplifying the power of what clinicians and non-clinicians are doing now to make their jobs easier. That's where I think I'm really excited about, applied artificial intelligence.
So it's almost like you hear the saying all the time in healthcare, especially with respect to like nursing and pharmacy, like working at the top of your license, right? Extracting as much value out of that person in that role, given their experience, and having doctors not have to do tasks that, let's say, a nurse practitioner do, or a nurse practitioner not doing tasks that a traditional nurse, and then traditional nurses, what can an MA do? And you can do that all the way down the line. Where AI can come in to really be able to extract, like a human doesn't need to touch this. And as long as it's
Well,
part of the workflow, right?
that's exactly right. But it's not just playing at the top of your license. I mean, that's what you do in a MASH hospital where all of the lower level military techs handle things unless a surgeon needs to, or a interventional person needs to deal with it. And so you leverage a doctor much more effectively in a combat situation than you would even in a trauma hospital, like in Chicago, where you're from, where there's a lot of violent trauma. That's absolutely right. You can allow them play not just at the top of their license clinically, but potentially higher, because the nurse practitioner now has more visibility, more diagnostic tools, and more information in real time than they had before.
Mm-hmm.
But I'm saying that there's an entire back office of bureaucratic BS that they are having to handle every day that's tamping down the ability that clinicians have to really care for patients. And that's at Waystar. We're just trying to take a lot of that administrative crap and make it and eliminate it by making, and then clinicians and non-clinicians can focus on the patients who need them.
Makes sense. So last topic, being aware of the time, You have a new book, Pay the People.
Mm-hmm.
Tell me. So we're going to shift a little bit in healthcare, although you may have some examples from healthcare. What drove you to work on the project? What drove you to write the book? And tell me a little bit more about what that's all about.
I'm so excited, and thank you for asking on a healthcare talk. But I was a healthcare CEO. I am a healthcare CEO, and I was the CEO of a company called CareCentrix. Like a lot of healthcare companies, a third of our people were entry-level workers. This is 12 years ago, and I just thought paying people $7.25 an hour, even if they're willing to work very hard and were happy to have those jobs, that was insane because it wasn't a living wage. And so I froze executive salaries and brought everybody up to $15 an hour 12 years ago. Now they're making north of $20 an hour, the entry-level workers at CareCentrix. And the premise was simply that you can't bring your whole self to work if you can't survive on the wages we're paying you. And I believe that the premise of Pay the People, why a higher minimum wage is good for business and great for America, is that we have a social tax that's tamping down productivity. It's screwing up families' ability to actually function as families because entry-level workers are working 1, 2, 3 jobs to pay their bills. People are super stressed who can't afford their bills. We've got millions of employees in the United States, full-time employees, leveraging public benefits in order to survive on the poverty wages they're being paid. And I found that when we dramatically increased the base pay to a living wage, our turnover got reduced, the number of people, the productivity enhanced, our people paid more claims more effectively, people answered the phones more effectively, productivity went up. But it also changed the culture and allowed people to really perform better than they ever thought they could. And so it dramatically helped my company. I think it can dramatically help the country if we can start to set a fair wage level to a living wage and have all businesses start to move in that direction.
So I am going to throw a healthcare question at you then. What do you say to the home? Because I know this is part of that business, and you're familiar with it. What do you say to the home care company or home health care company that says, I have to pay my people $12 an hour or $14 an hour because I can't make any money. I need to have somebody in the home. And I'm thinking more of like private duty home care, but what do you say to them?
John, I say, look, if you have a model that you can't pay someone a living wage, it's not a real business model. Find another
Thank you.
business.
Thank you. That's the answer,
It's that
right?
simple.
I mean,
it's that simple.
Figure out a new business model.
You figure out a new business model because otherwise you're having the taxpayer pick up the difference. The mothers are not going home and taking care of their kids. People aren't eating nutritional meals. There's more people on Medicaid. This has a much longer paying poverty wages may work for that business short term, but we're all paying for it in our society in the long term.
Well, as a small business owner, we've got 30 people here. I can tell you that it's true in big companies too, but if I don't pay people enough, if I don't pay people what they're worth, if I don't pay them certainly a living wage, they're going to find a place that will, and I'm going to lose people. And it's a lot more expensive to find new people and hire people than it is to keep the ones you have.
Biggest unrealized cost is all of that turnover because people are desperately chasing the next paycheck. It's not good for companies. It's not good for society. We need to fix it, John. But pay the people, well, there's lots of solutions.
Well, John, this has been an absolute pleasure. Go on and on. Maybe you can come back in 6 months. Maybe we've got something new to talk about. But I want to thank you again for taking the time to meet up and cover so many issues in a short period of time. So thanks again. And that'll do it for another episode of Healthcare Rounds. If you can, give us a rating wherever you listen, if it's on through Apple, Spotify, or if you're watching us on YouTube. Please rate the show and be sure to follow us. So see you next round.